in case I start swearing or something.
Yes. Yeah, put an explicit square. Hi, I'm Dr Bernard Siew, and welcome to The Bite Angle, our podcast from the Dental Designs. And I'm actually a dentist at Dental Designs. And today we have a special guest joining us. He is Dr Kenneth Oo, and he is an ENT specialist. So Kenneth, I'll leave it to you to introduce yourself and what you do.
Yes, thanks Bernard for this very nice meeting and this opportunity to talk about the things that we do. I'm an ENT currently practicing in Mount Elizabeth Hospital in Orchard. I've been an ENT for the last 20 over years, and it's basically a very, very interesting field. We deal with kids, adults, aged people, and there are all kinds of evolving things that are going on with the ENT discipline, and a lot of collaboration these days with cross specialties like respiratory doctors, dentists, neurologists. So it's a great opportunity today to discuss about some aspects that we are actually doing.
Yes. And for the uninundated, ear, nose, throat would be the longer version of the ENT, right?
Yes.
Yeah. So.
So I mean, I think most people locally here would call it ear, nose, throat. It's more in keeping with maybe our British heritage. If you go by the more American terminology, people will be more familiar with the term otolaryngology.
Oh, right. Okay.
Which is a little bit of a mouthful for a lot of people. So ENT is very easy, very simple: ear, nose, throat. But just don't confuse the ear with the eye, which a lot of patients sometimes do come in and tell us, "Oh, do you see?" and look at our eyes as well. No, it's ENT, meaning ear, nose, and throat. Yeah. So everything in the neck, in this region, in the head, short of the brain and the eye, is managed by the ENT.
Oh, right. Okay. Yeah. So the eye is partially involved, maybe. Right.
Sometimes, so that's where we kind of work with our fellow specialists.
Right. Yes.
So some conditions do involve the nose, sinuses with the eye, or the sinuses in and the ears being very close to the eye. Then we would work and collaborate with our eye specialists. Yeah. So that's where all this collaborative work happens.
Because our bodies don't work in isolation, obviously.
Correct.
Right, yes.
And conditions don't isolate themselves to very specific anatomical places. And so that's why we need that cross specialty, the experience from other specialists to kind of really treat our patient holistically and get them better.
Yes.
Yeah.
So actually, what has been very more noticeable in my practice is that I'm getting a lot of grown-ups coming in with snoring issues.
Yes.
Perhaps it's something that has always been there and people are just more aware, or maybe that there has been a change in our lifestyle that has caused the increase of snoring. But these were one of the things that we started to delve into. And snoring, I've later on discovered and further study, is part of an issue that we deal a lot with sleep medicine as well. So it's sleeping and breathing during our sleep, right?
Yes.
So that's where we've actually collaborated before.
Yeah.
And so let's give us an idea of like how often do you deal with people coming into your office with snoring issues? And do you get a lot of people coming straight to you, or do you get a lot of doctors or dentists that tend to refer to you about that?
To put things into perspective, I think there's been very good studies over the years, general population studies of the incidence, the prevalence of snoring, sleep apnea. And if you look at the local data, the adult population, it's really quite significant. About maybe up to 30% of the adult population has got some form of snoring and sleep disordered breathing issues. And the worrying thing is that of this 30%, and that's like 1 in 3 adults. 90% of them do not realize that they actually have a disorder. So you're really essentially seeing the patients whom you see are probably the tip of the iceberg.
Wow.
Of the extent of the problem.
Yes.
In the general population. And the Asian numbers are much higher than, say, the Caucasian population. We think and we attribute that to certain skeletal evolutionary differences that we have in the shape of our facial bones.
Right.
Asians being a little bit more shorter in the anterior posterior, meaning the front back proportions compared to the Asian population. And so we see a lot more essentially obstructive sleep apnea, a lot more sleep disordered breathing issues in our local context. And you're right about the awareness. I think the problem has always been there. It's just that increasingly with more education, with more publicity, people are beginning to realize that, hey, yeah, maybe I do have a sleep problem, maybe I do have sleep disordered breathing. And of course, over time, compared to, say, our grandparents' generation, I think weight gain has been also an issue. And so all these contributory factors have made sleep disorders, obstructive sleep apnea, more and more commonly seen these days.
Yes.
And your question about whether they come in directly or whether they're referred, I think it's a good mix. Patients who are more informed, which is like the vast majority of the younger population, the Gen X, for example, they would often come in on their own. The slightly older generation patients tend to be referred by their GPs, their dentists, sometimes from fellow patients, sometimes from their concerned family members, because they've observed kind of disrupted breathing at night, choking episodes, or they have very poorly controlled, like hypertension, even though they are taking their medications regularly. So various streams, and it does. There is a slight difference in how they come depending on their age group. Yeah, right. I must say.
Okay.
Yeah.
Yes. And so do you, is it also very much age related, or do you tend to see quite a number of kids also with sleep breathing issues?
Yeah, so I would say in my practice I see two peaks. One is the pediatric age group. They are younger. They're probably maybe sub 10. And these are often either referred by their GPs or their pediatricians. And increasing with education, parents are actually noticing that, this is not right. Yeah, my child is snoring, having a very, very poor sleep, very tired in the daytime. And so they would bring in their kids with snoring issues. The causes of snoring in that group versus the second peak. The second peak is typically a bit more middle age or just below middle age in their 30s and 40s. These days must be careful with the term middle age, right? Yes. Yeah, so 30s and 40s, I would say that is a very, very common group. The active working adults, maybe a little bit less time to take care of their health and diet at that point in time, still really hitting their work and their work commitments very, very hard. So they put on a little bit of weight, they do a lot more eating outside, drinking, etc., smoking. So lifestyle not the most ideal. And so that's the other big group that would come in for snoring. And so the causes for these two groups are rather different.
Right.
Okay. Because one, for example, just to illustrate a typical pediatric case, most of the time they have either blocked up noses due to allergies, uncontrolled allergies, causing sinus issues, causing very, very congested nasal passages, or they have huge tonsils, huge adenoids, a combination of both. And then, of course, there's a smaller subsection, such a smaller number with like tongue tie issues,
Right.
where we may have to address that.
Yes.
For the adult segment, then you get a lot more issues with already distorted, say, chronic dental facial growth issues. So they have maybe very small midface because they've been chronically obstructed since their childhood. Therefore, nasal passages are totally obstructed, or they have a deviated septum because the maxilla, the midface, didn't grow very well. And then they have long, floppy palates, very, very posterior placed tongue base, obesity sometimes, or excessive fat in their neck. So all those just shows that, it's different from the pediatric age group. But when you put things together, you can actually imagine how it evolves from the child left unchecked, untreated, and then it moves on to
So
teenage, 20s,
gets worse and
30s.
worse, yes.
Yeah, and then it causes sometimes very, very permanent, long-lasting changes that almost condemns them to
For sure,
obstructive
yes.
sleep apnea
Yeah.
by the time they reach adulthood.
Yes.
So I think that's where I think a lot of collaboration can come in.
Exactly, yeah.
Preventive medicine.
And so the one thing that we try to do when we see children is that, and I try to explain it to the patients and their parents, is that we don't necessarily just look at cavities or decay in the mouth, but more so about reaching milestones with development of the jaw, right? And we tend to look at the tongue, like you mentioned, the tongue ties, and sometimes even with lip ties. What I tend to look out for is just habits from the beginning, because if we see someone that is mouth breathing, so oftentimes when I'm talking to the parents in the room, I'll just let the child sit in the chair, and sometimes I'll just lie them back and just watch them, and they would absent-mindedly either mouth breathe. So if they're mouth breathing, then I'll ask the parents, like, sometimes they're not even that aware or mindful that the child is actually having the mouth open all the time, and that's actually a sign that they are breathing through the mouth. But what happens is that the jaw changes very significantly and becomes very narrow. And so the other thing to explain to the parents is that some habits can come in either before or after the fact, but thumb sucking or lip sucking like that, just to create a seal, and that exacerbates the problem. Like you were saying, with Asians, especially the lower jaw and the mid-face area tends to be a little bit flatter and instead of more prognathic, right? And so if we're looking at overall volume, capacity for air to go through, we forget that actually the upper jaw is the bottom base of the nasal cavity, right? So if you get a very narrow cavity, then there's actually less airways that can be used. So typically, I guess we can run through a couple of scenarios that we've actually dealt with together. One was actually involving my son, right? So he had he had constant sinusitis problems that took a long time to go away, and then he came to you, and we discovered that his turbinates were very enlarged. Yes. Can you tell us a little bit more about like the turbinates and the septum and what it does actually in the mouth?
So we all have turbinates, right? They are physiological, they are structures that are meant to be there to help humidify, warm up the air, filter some of the particles that we breathe in on a day-to-day basis before it reaches our lower airway. Right. So they are actually very important structures. You can imagine them as almost like filters, right? So we essentially have 3 turbinates on each side. So it's very easy. It's the inferior, which is the lowest most turbinate, the middle turbinate, and then the superior turbinate. And most of the time, the turbinates, if they are functioning normally, it causes air to flow very smoothly. If you've seen like those aeroplanes taking off, you have this thing called laminar flow where the air flows nicely over the curve of the wing, right? Or of the aerodynamic structure, right? And so that's what the turbinates are supposed to do, right? Humidify, warm up, and provide
Slow
that
the air,
laminar flow
right.
through before it reaches your lower airway. But unfortunately, allergies are so common these days. Pollution is very common. That's a separate thing that would cause turbinates to get inflamed, right? So the allergies, like in this part of the world, house dust mites, super common. To some degree, pollution as well irritates the mucous membranes that line the turbinates, and so it gets inflamed. If it happens 1 or 2 days, it's fine. Like say if you get a viral cold or flu, your nose bungs up and then it resolves, that's fine. But imagine day to day you're being irritated by house dust mite allergens. After several years, it will almost like permanently swell up.
You mean like a scar?
Not really a scar, but it gets filled with inflammatory cells, inflammatory chemicals.
Right.
And it stimulates the lining, the mucous membranes, to become so engorged. Right. And then blood flow will all increase because there's a lot of inflammatory chemicals.
So it's almost adaptive.
Adaptive, and it adaptive in the wrong way, right? So it's trying to respond to the allergen, but as a result of that, all this inflammation happens, and so the nose gets blocked up. In children, what we seldom see is like a deviated septum,
right?
Because typically, unless it's due to birth trauma or some congenital malformation, we don't really see deviated septums that frequently.
So what causes deviation?
Deviation, okay, that's something that in general, two possible reasons. A very acute deviation is typically like due to trauma, right? So you bump your nose, or not only
not breaking the nose, right?
Not necessarily breaking the nose, but maybe like a hard knock,
right?
Or sometimes what I've seen, I don't know whether it's been described, but it's like long-term, low-grade, repetitive trauma. So, for example, nose rubbing. So the kids will rub. Every day, you can imagine if a cartilage was being rubbed. This is what I think. It rubs, rub. Eventually, it will bend. It will buckle. And one of the sure things that I've seen, and I call this my COVID nose, is mask wearing. During that period where 2-3 years of mask wearing, and some patients who wear the cloth mask with no flexibility at all, is very taut. And how I can tell that it was due to the mask was that I've seen these patients pre-COVID. And when I finally see them again, they say, "Doc, my nose is blocked." And I look in, and I photo document all my patients from before COVID. And then after COVID, they come with a deviated septum.
My goodness.
And the only explanation is that they've been wearing their taut mask for the last 2 years. And that essentially bent and buckled their septum. They probably had some mild deviation to start with, but really with that constant pressure, the septum eventually bent. So it can be acute, it can be low grade septum. And then the last one that we mustn't forget, which is what we are trying to do for kids, is preventive. Because if the midface doesn't grow out due to chronic mouth breathing, then this part of the face and the upper jaw or the maxilla doesn't grow out, doesn't expand, then where's the septum going to go? It's just going to have to find room, and it will buckle. And so that is the other big group that I see in adulthood in their 30s and 40s with deviated septum. And you can look at their face, they have all the hallmarks of mouth breathing. A very heavy lower jaw, open kind of mouth. Their dentition is just overcrowded, very hypoplastic. And then you look inside, their septum is buckled. There's no space for the cartilage to to grow out straight during that teenage years.
Yeah.
Right. So that's that different groups that we spoke of. So like back to your son, so allergies cause turbinates to be very, very grossly enlarged. If you don't do anything about that, if you didn't do anything about it and just have the typical, now this mentality is very disturbing, and I always tell my patients, you have to not be so fatalistic, because a lot of patients say, oh, allergies, they will eventually grow out of it. Now that is not true. They don't grow out of it, they normalize. Right? So they adapt.
You just get used to it.
They get so used to their blocked nose, and what do? They convert to chronic mouth breathing. And then they adapt, they become normalized to a chronically obstructed nose. And then you develop the secondary problems of mouth breathing, structural deficiencies in their dental facial growth, sleep apnea, tonsillitis. Then they start to get frequent sore throats.
Because they're breathing through the mouth.
They're breathing through the mouth. Then the tonsils becomes like the gatekeeper. And so that's where some of these kids get recurrent tonsillitis, enlarged tonsils, then go on to OSA because the tonsils become so big. So one thing leads to the other, but actually they could have sorted it out years ago if they had just improved on the nasal breathing. So that's a pretty uphill task over the years, because we have to just reach out patient by patient, one by one, telling them this story over and over again, that look, it's not something that you grow out of, it's something that your kid normalizes and adapts to. And it doesn't mean that they're well, there's going to be a problem, right? So,
I've seen, and you've seen quite a number of my patients who are of like a younger age too. And the first thing is just to make them aware of it. But I would say it's probably at best 50% that they would take it seriously enough to take it to the next level. And it's, I mean, even with my son, we noticed that, I just noticed that it takes him 3-4 weeks for him to recover from anything. And then we did talk about options, right? So when you have a lot of swelling in the turbinates, what can you do? So I like your approach where it's not always just, let's just go and do surgery, because sometimes people are not very mentally prepared for it, right? And so we tried reducing the swelling by means of
environmental control,
environmental control,
and then nasal steroid sprays.
That's right.
Trying to find out what is he allergic to, for example, so they can avoid it, right? So those are usually very, very sensible first steps that anyone can take, right? And it's very easily accessible. But be mindful that when you go on that path, there must be a checkpoint, right? So you want to have checkpoints at say 1 month, 2 months, and reassess how is the kid doing. Because it doesn't. So we have the other group where unfortunately they fall off because they said, I went to the doctor A and he says that he's allergic to dust mites. We put him on nasal steroid sprays. He didn't get better, and so we just gave up. We just stopped, right?
Yes.
Because we thought that was it. That was all that we could do. Right? So that's the other thing that it's something that we need to speak to our patients that look. I mean, this is the first step. If he responds 1 month, 2 months, fantastic. Please carry on. But if he doesn't respond, don't be worried. There's something else that we can look into. Let's see how we can work on this to get it better, because that's not all that we can do.
Exactly. And then from our point of view is that, so we have patients that come in and they might be dealing with, let's say, a very narrow jaw, and the parents are noticing, can you do something for my child? I can see that there's a lot of crowding. I had it when I was a child, and I would need braces. Can this patient have, my child have correction that way? And then we take a dental X-ray, and we can actually see very clearly if there's a lot of anatomical issues on the nasal cavity.
Yeah.
And the first thing that I would want to mention to them is that yes, we can actually expand the arch, do all those things, but if we are still then fighting against the mouth breathing issues because he or she cannot breathe through the nasal cavity, then we are fighting an uphill battle because the muscles in the jaw to try to pull air in will actually undo everything that we're trying to do.
Right.
So it has to be like a multifaceted approach.
Yeah.
And I mean, ideally, that would be the case where, if the parents buy into it, that they see the ENT, and so then we can also manage the upper airways.
Yeah.
But sometimes if not, we tend to actually have an appliance for the children to expand the jaw. We try not to now extract teeth.
Yeah.
And pull everything back, because again, if you think about it, it's like taking furniture out of a room
That is
instead of if you have the chance of expanding the room, making the room bigger.
Yeah.
And then actually, and I saw it with my son. It's that because I've got the at least the benefit of knowing the science behind it, and then to monitor to see actually he had earlier signs of maxillar constriction. So the upper jaw was a little bit
narrow,
constricted,
right?
almost to a crossbite. And after we fixed it at the age of 4, now he's 7. Actually, the jaw's just expanded by itself. So then we don't need to do anything more major. So that's the other thing as well. Early intervention is key. And sometimes it's more difficult if we deal with it dentally. So we try to look at the overall approach. But now approaching to an adult who's had these issues, never been dealt with correctly. So we had this one patient, Bob. I remember him because he had very severe sleep apnea. And he was not aware of it. Interestingly enough, we saw that there was a lot of grinding patterns on his teeth. He was starting to crack a lot of teeth. And we used to think that grinding was isolated and not related to sleep apnea issues, but we realized that actually it's from labored breathing. So then sent him to you. And then how did you manage him from there?
So these patients who come in for snoring and sleep apnea, possible sleep apnea, is very, very important to get a very good history because like what you say, patients, even a lot of medical professionals, they may not realize the significance of certain things, certain phenomenon that's happening to them. For example, like teeth grinding, they'll say, maybe it's due to stress. I mean, traditionally, people always say, you grind your teeth because you're stressed. But these days, we know that a lot of grinders grind because they have sleep apnea, right? So it's sleep bruxism. And so important things, we need to ask them about these things that may not be apparently linked to their sleep apnea, but we would still want to ask them, do you grind your teeth? Do you wake up with a dry mouth? Of course, do you snore? Do you wake up in the middle of the night to use the bathroom? Because that's sometimes when they reach middle age, they say, it must be my prostate or something like that. Right. But actually, no. You send them to the urologist, it's normal.
It's because they wake up.
It's because they are waking up because they're not getting deep sleep, right? So they use the bathroom many times.
It sounds like me.
So it's like it's things that apparently seems unrelated, but as a physician who practices sleep medicine, someone who sees sleep apnea, we try to ask these questions. And like things like hypertension. I have hypertension and it's so difficult to control. It's always so high in the morning. Now these are like ding ding. Right. Maybe he has sleep apnea. So that's things that
red flags.
Might come to the physician's mind when the patient comes to you with these symptoms. Then of course we run the physical examination of the upper airway. So very often, I would say that if patients get diagnosed or they suspect they have obstructive sleep apnea, please have the upper airway assessed, because if you just slap on a CPAP, yes, that will overcome all the obstruction, but you might want to have a more precise idea where exactly is the obstruction. Is it in the nose? Is it in the palate? Is it in the tongue? Right? Why are you just pushing through the airway with a machine and not even taking the next step to find out where is the level of the obstruction? Because it could very well be very easily solved, right?
Yeah, exactly.
For example, maybe it's just a turbinate enlargement, or maybe it's just huge tonsils. Then once they are actually sorted out, your sleep apnea is resolved, you want more precision, right? So we would run the nasal scope through, just look at these levels, the nose, the palate, the base of the tongue, do some dynamic breathing maneuvers to see whether it collapses. And then the other thing after that, we do the polysomnogram, which is the sleep study, just to have a complete picture as to the extent of the sleep apnea. Is it mild, moderate, severe, positional, or
there are sleep monitoring devices now. How does that vary in accuracy and depth compared to like a polysomnogram you were talking about?
So I think we are very privileged in this day and age that we have come to a phase where technology has really caught up with a lot of these aspects of biomonitoring, right? So there are so many wearables these days. It can be in a watch, a ring, it can be a necklace, it can be even something on your ear, and it monitors like your oxygen levels, your heart rate. Those are pretty standard, and then the software within these devices with their proprietary kind of technology to monitor the depth of your sleep.
What do you use
for
with
monitoring?
Your patients?
So I think for diagnosis, I would still recommend that you go for a full polysomnogram rather than relying on these wearables until the day that the wearables have been verified to be as accurate as.
At the moment, it's not.
At the moment, it's. I would say none of these rings or these watches can compare, because the main limitation I would say is the EEG. Right. So the EEG. Which
and explain to us what the EEG is.
So that's electrography of your brain waves.
Right.
All your delta waves, your alpha waves, that monitors your sleep, whether it's in the deep phase, the REM phase, whether it's in the shallow phase, and that's still the standard, the gold standard in monitoring whether you have gone into that phase of sleep. Everything else, like the wearables, would be extrapolating from data that they have gathered.
So it's a guess, really, not
I mean,
direct.
they're pretty scientific. I mean, they go through great lengths to try and perfect it. But of course, there's limitations. And so at this point in time, still can't quite have 100% correlation with the EEG. And so that's where the polysomnogram for diagnosis would still be the gold standard.
So where do you do the polysomnogram? Do you do it at home for the patient?
Vast majority these days of sleep studies are done at home.
Right.
So the sleep tech comes over, hooks the patient up with all these leads, EEG included. They can add in the bruxism lead.
Right, okay.
And then the patient falls asleep, the device records automatically. And then the next morning, they come retrieve the device, and then all that information goes into a cloud and then gets analyzed by the sleep tech, and then we get the report, and then that's how we get the results. The usefulness of the wearables is for monitoring.
Right.
So because you can't be doing a sleep study every day. And it's in a lot of patients it's rather uncomfortable. So you want that for diagnosis, but after intervention, or if you're monitoring the patient who is using CPAP, for example, a ring or a bracelet is super convenient, and you can these days with cloud you can literally track how they are doing, their usage, whether their AHI is corrected. So we have a wonderful kind of tool and technology these days to be able to do that for our patients, which we never did. Just like maybe 10 years ago, you wouldn't have had this opportunity. You would still be kind of guessing how they're doing on a day-to-day basis, but it's great these days.
And sleep studies used to be done in like a hospital environment.
Yeah, so a lot of times previously sleep studies used to be done in hospitals. I guess when it all started, it was in the hospital, and then the sleep tech, the therapist would be actually in the next room observing, etc. There are still very, very few cases where patients would require that.
Right, okay.
Now, those are very complex cases.
Right.
Where they may have central sleep apnea, they have a lot of other neurological issues that are complicating their sleep.
That makes them stop breathing.
Yeah, that makes them stop breathing, not only due to obstruction. And in those instances, yes, perhaps an observed sleep study is warranted, but I would say it's extremely rare. Yeah, extremely rare these days. And the benefit of the home-based sleep study, obviously, is that much cheaper.
Yes.
Right, you don't have to pay for the single hospital room. And then the thing is that it's also more comfortable. It's more reflective of your usual environment in which you sleep in, rather than on the hospital bed with some outside bells ringing because someone has pressed a call bell, that kind of thing.
Yes.
So, and of course, the good thing is that the research has come in over the years that has verified that home-based sleep study is as accurate as the hospital-based sleep study. So why not?
That's great. Yes. So going back to Bob, I think what happened to him was that he was then diagnosed with quite severe sleep apnea. Yeah. And then he was suggested to get CPAP. Yeah. So explain to us about the CPAP.
Yeah. So typically you can manage sleep apnea with various means. Typically, if you're talking about a non-invasive or less invasive, it's still to some degree, some patients will argue that's invasive.
Right.
But less invasive way involving no surgery, then CPAP would be one option. Your mandibular splint would be another option.
Yes.
Typically, CPAP is useful for the more severe cases.
Yes.
I generally wouldn't offer CPAP for a plain snorer or a mild sleep apnea. I mean, what are you trying to do? You're just kind of going to hook him up to a machine and face mask for the rest of his life.
So describe what the CPAP looks like.
So the CPAP, again, with technological advancement, it has become smaller, but it's still like a box, right?
Oh, okay. So it's not like a full oxygen tank, right?
No, it's a box that you place by the side of your table. And it has like a one main tubing that comes up that delivers the pressurized air.
Yes.
Right? So it's not oxygen, it's air. There's no oxygen concentrator or something connected to it typically.
Oh, so is it like an air purifier type
there is a filter. There is a filter, which is a whole different topic about the filter. That was a problem a few years ago.
Right.
But they all have a filter and a main pipe that comes out that delivers the pressurized air. And that is then delivered through a mask, what we call a mask. It's either the most comfortable, I would say, would be a nasal pillow. It's easiest to adapt to because it just sits under your nostril.
Right.
Soft silicone kind of material with a strap going around your head above your ear.
Yes.
And then sometimes even an attachment under the chin.
So it doesn't get dislodged.
Yeah, so it doesn't move or fall off. That's relatively comfortable, but as you can imagine, to some patients, it's still not comfortable.
Yeah.
Right?
Yes.
Then there are other options like a nasal mask. So that's like a full triangle covering your nose. And then you strap it on. And then there's a full face mask that goes nose and mouth.
Wow.
And then it straps on. And then you have a full face mask, like a
Really?
like a almost like a
astronaut.
like a scuba, like astronaut. It goes around the whole face.
Yeah.
So so that usually is something that our sleep therapists who are excellent, super well trained, they would be the ones fitting these masks on the patient, and obviously they try to use the simplest, least uncomfortable, least involved mask first, and then they would then escalate. If, for example, they can't get a good seal, it keeps leaking, then they'll get a bigger and bigger mask to try to overcome that leak or that seal. But the bigger the mask, the more uncomfortable it is, obviously, right? And so a CPAP trial is very, very important. We do that for all our patients.
So what's the CPAP trial?
So we just put them on the CPAP. The sleep therapist will give them the best fit that they feel that would suit the patients, the best, most suitable machine that they think would work for this particular patient, because there are different machines, right? Different machines, different settings. There's CPAP, there's BiPAP, depending on what the patient requires. And the 2-week trial runs, and then from the data that, again, these days with technology, is all captured on cloud. We can just look at the performance of how the patient is doing. Then we make the necessary adjustments after that 2 weeks. If 2 weeks we adjust, still doesn't work out, 4 weeks doesn't work out, then sometimes we deem these patients CPAP failures, right?
Right. And what do you mean by not working out? It's just that they can't. They
the usage, for example, so the data will come out like basically this magic 4-hour thing. So any usage beyond 4 hours is deemed as success, right? Per day, per night, right? So they will go on a trial for say 30 days,
right?
And then if of the 30 days they only manage to use 50%. Then that's not good. That wouldn't work, right? In the long term. If it's the first time they're using and you get 60-70%, possible. Maybe they're just getting used to it. Then just push them a little more and see if they can climb that usage to about 80-90%. So usage is one measure, and then you must look at the AHI. AHI is the obstructions that they get while they're using the machine, and the machine will record it. And of course, if anything less than 5 or close to 5, you would deem that as a success. If they are on the CPAP using it more than 4 hours, and I seldom see this, and the AHI is still high, then obviously it's not working, but very uncommon. Most of the time, if they use the CPAP, the AHI will be corrected, right? And then, there are other parameters that we look at, but those are not so important. So once they are satisfied we are satisfied, patient is satisfied with the trial, they purchase the machine. So we don't encourage patients to just, a lot of them these days with online shopping.
Right.
They will just buy.
Really? All right.
Like, it's cheaper. It's cheaper than what the sleep therapist does.
Yes.
But you don't realize that what you're paying for, the extra few $100, it's
the trial,
the professional advice, the troubleshooting, the measurements, and how they eyeball the patients and say, I think this mask or this machine, this setting is most suitable for you.
Yes.
They think, it's auto CPAP, it just sense, and they'll just slap it on, and then it should work, right? But no, it's more complex than that. Even to the degree of how you line the tubing, so that you have more freedom of movement of your head is very important. So you can't just go out, buy a machine online just because it's a few $100 cheaper, and then expect that it would work as well as a professional who's done this for decades to actually adjust these things, these nuances for you. And so we always try to emphasize that. And anyway, they lose nothing. They just go for a trial. If you don't like it, then you actually save more money.
You do.
Rather than you buy it as a trial. That's crazy.
True. And so the compliance or the success rate of CPAP is not great, right? It's not typically very high.
That's where my experience varies. So I know in general the data is like telling us 50% success. But if you put them on a trial, if it doesn't work, that sees off like 40% of that 50% that failed already.
Yes,
right? And
that's
then
right.
you're left with almost a captive group.
Yes.
That is very likely to work already.
Yes.
And for that group to then subsequently fail over the years is very uncommon.
Oh, good.
Yes.
Right. So that's good to know.
Yeah,
so most of that failure happens very
Early on.
Yes.
So that's why, so I think, I'm not sure whether that data takes into account that 50% that fell off was put on the trial. And therefore, they included the people who failed the trial as all that 50%. So by the time I select a patient for CPAP, put them on the trial, and weed out those that totally cannot make it for the CPAP. And I follow up on those patients who finally take on the CPAP, very few failures. Yeah. So I think
that's good to know.
It's an important kind of perspective and way to stream the patients and select them so that you reduce your CPAP failures.
Because we have to put that in context, because when you tell people 50% of the time people don't make it past a certain level, then you just go, oh well, then what's the point?
Then what's the point, right? And then they'll opt for something else, right?
Exactly. And that's when they come back to me, right? So the alternative we have is the use of the mandibular advancement device. It's basically to partially correct during sleep the collapse of the lower jaw, really. And I think in Asians it works quite well because of the smaller jaw anyway. But it is not the most comfortable thing to wear. And I'm always very surprised that patients tend to tolerate it relatively well.
That's because it's done by the dentist.
Yes, I have had patients that come in with bought online
over the counter. Exactly. This
and
online
they go,
thing.
oh gosh, I thought I would save myself money, but I've just wasted a few $100.
And have you seen those that use they try to suck their tongue?
Yes,
they buy online. They
I know.
create a negative pressure,
it
and
looks
then
really
it
weird.
Sucks their tongue out of their mouth. And then they wear it like that. I'm like, I don't think that's gonna work.
It's a very bizarre looking device too. Yes, but it's very surprising. But a psychologist patient of mine shared with me, and she said, this is a very interesting fact. She says that snoring has become such a problem that she sees it as a relationship issue, right? So she says, as a relationship psychologist, what her patients go through now is called sleep divorce. So, which means that they sleep separately. And that saves their marriage. And oftentimes I get patients coming in, mostly men, but not always, that they will come and go, hey, my wife's complaining so much about so I said, well, if you wear this device, so far it's almost been 100% success rate when it comes to stopping the snoring. But the first thing that I would tell them is that we need to ensure that it's not just the snoring that we stop, but that your sleep breathing is actually better, right? But the other thing is the biggest gauge will be
the missus.
The missus, just your sleeping partner, whether they are now happy with it. So oftentimes I would involve the sleeping partner and actually ask them, so how's the snoring going, right? So that's have we solved the problem?
Yeah, that's an important point. You see a lot of that issue.
Exactly. Apparently there's there is an app that can monitor your snoring.
So there
it records your snoring, right?
So technology is fantastic. So Snore app is one of the popular ones.
Yes. Have you tried using it yourself?
I've not tried. I've not tried. But my patients would whip out their Snore app and just show me.
Oh, okay. Like they'll play it for you?
Some of them will play it. Some of them will actually show me the degree. Because it has a report, a summary report. So all those are actually useful adjuncts when we want to manage patients, depending on what they walk in with their complaint, right? Their complaint is primarily noise of snoring, then really there's no point trying to convince them that they need their turbinates reduced or their allergies treated. They just want, at the end of the day, their noise of snoring to be resolved.
Yes,
right?
yes.
So that's one of the things, the targets that you have to achieve for them. And I think patients who, for example, have a lot of bruxism, I find they do very well with the mandibular splint, because I always tell them it's a 2-in-1.
Yes,
right?
it's 2-in-1.
You
It solves
correct
two
your
problems.
snoring, you improve your OSA, and there's no way you're going to grind your teeth if you have a mandibular splint. So
you
why
want to,
not?
it doesn't matter.
I think that there is a need to really understand your patient's main complaint.
That's right. Yeah.
Really work them out medically.
Yes.
So that you don't want them to suffer from complications from sleep apnea.
Yes.
And then finally, tailor their management to the degree as well as to their main issue that bothers them, so that everyone is happy at the end of the day. The worst thing would be to recommend the same treatment for every single patient, right?
Indeed, yes.
So you could cure sleep apnea by insisting on CPAP for every single patient.
Yes.
Right?
Yes.
But that's not the way to go.
No,
That's in my books, I think that's wrong.
Yeah,
Neither should you just take out their turbinates, take out their tonsils, straighten their septum, do a U-triple-P, reduce their tongue for every single patient.
Yes. It's
that's
like
wrong.
killing
That's
a fly with a cannon, right?
exactly, yeah. So
Yeah.
it has to be really tailored to all these aspects, these three main aspects. Why the patient came to see you, what is his medical issue coming from his snoring or sleep apnea, and then what specific anatomical correction you're going to offer for this particular extent and this complaint.
Yes. And I think that's why I wanted to have you here to talk to us today, because I think a lot of times people are almost too afraid to go into a specialist to see. And I've even had patients that go, no need, because I'm afraid the doctor will just say, you've got to do surgery for everything, right?
Exactly,
and so then at least they can, the public can have a better awareness of what we look out for, but also your options, right? So we always start with the lowest form or easiest, most conservative form of treatment. See whether it works, move on to the next. And it's multidisciplinary. So it's not unusual for us to then refer you to a doctor, and then just to get that checked out. And then we actually have a discussion about what might be the best way forward. Because like for Bob, he was actually at the start very keen to get the snore guard.
Okay.
And I said, I don't want to make it for you unless we make sure that it actually solves your overall issue. Because yes, I can give you the guard, that's great, but and you use it, maybe the snoring stops, but the sleep apnea is still not completely resolved. So by doing this, at least he can get better. And if we still need to make the snore guard, then we will. But I
think even the patient will be very convinced if he eventually needs the snore guard that he really needs it.
Exactly. So
he's already tried,
explored the different avenues, right? But some people are a little bit different in their approach, as in with the individuals as our patients. And some will go, why not just I don't want to do one thing and then not work, then why not just do everything, right? Yes. So okay, that's also fine, but with everything that we do, there's also an associated risk.
Exactly.
So as long as they're aware of it and they're fine with it, then that's okay too. But I guess the take-home points that we want to bring in now is one, is that when it comes to what we examine in your mouth and the nasal and the breathing passages, it's multifaceted, so it can be done in different ways. The other thing is that the approach to treatment can be either in the mouth or it can be actually from the nasal passage as well. And sometimes we might involve another person who's the oral surgeon. Right? In some cases, the jaw is too small. So I can't push the jaw forward enough with an appliance, and you can't, reduce turbinates enough
I can't widen it anymore.
So if you imagine like the breathing comes from the upper airways to the jaw area and then down to the throat, right? So if the lower jaw is so small, we actually have to surgically move it forward. We hope that
so these are the patients that probably missed the boat, right?
Exactly.
So they were chronic mouth breathers since childhood.
And
so their mid-face, their lower jaw just never really grew very much. And then to complicate things, I think, I'm not a dentist, they had lots of extractions done just to straighten their teeth. And so everything just became frozen in that very 10-year-old size. And so the only way to actually improve it is to refer to an oral max-fax surgeon. And while we don't see that very much these days, there are still patients who will benefit from a Bimax. Right? They really need this whole complex to be moved out. Because you can see them, their whole face is like so tiny below the eyes. And so the oral max-fax surgeons would really be able to help this group of patients.
Exactly. And so then this could be like a prelude to, if you actually are concerned about the snoring issues, then definitely we will be able to assess it in the mouth and also through an ENT specialist as well.
And final shout out, I must say, is that recently I attended this meeting where it was multidisciplinary as well. And what was interesting to hear is input from physio, osteo, and chiros who are retraining the brain and the muscles after all that structural work is done. So I think we mustn't forget that I may widen the nose, do a perfect job, remove the tonsils, do a perfect job, and then the kid is still mouth breathing. Right.
Absolutely, yes.
So
habitual.
We need to do this myofunctional thing. I think it's kind of getting more traction these days. With dentists, with ENTs. I think the muscles need to be retrained, reprogrammed to actually breathe through the nose again, because maybe it's been so long since they last breathed through their nose. And so everything is open now, but they're still mouth breathing because the muscles forgot how to revert to nose
100%,
breathing.
And it's not all woo-woo, right? Some people think, wow.
So it's becoming more and more organized, more and more scientific. And there are patients and there are practitioners out there with more and more experience in correcting these patients who don't revert to nose breathing so easily, even after the anatomical correction has been performed. So I think it's really akan datang. I think it's really something that is interesting. I
for sure.
It's going to help a lot of patients.
And at least the awareness is out there now, and it's reaching a tipping point where people are now. I think sleep hygiene is super important, right? It's just we spend 1/3 of our lives sleeping, and I think it varies a lot and we've seen the differences in our patients' lives when they've corrected the sleep problems that they've had. It's day and night difference. And so
the energy and the mood, and some of them are so depressed because so many years they've not been able to sleep. And they have to cope with family, with work, and they are just so drained. And then when you get their sleep apnea corrected, they come in, they're like a different person. Right? So it's very satisfying to see and manage patients who actually make that U-turn, and that's great.
Great. Thank you so much for joining us today.
Most welcome.
Pleasure. For everyone, if you have any concerns or questions, please email us and let us know. And we'd like to speak to you more about it. Thank you.
Thank you.
There you go.
Thanks, Bernard.
Yeah, that was pretty cool.